Okay, so we are getting started now, and first of all, welcome to the second Northwest ATTC webinar of 2018. My name is Bia Carlini. I wear a couple of hats here at Northwest ATTC. Today, I'm wearing my webinar series coordinator hat, and I'm very excited to introduce our speaker, Dr. Michelle Peavy, who will be addressing the topic of patient-centered care for patients with opioid treatment in opioid treatment programs. A little bit about Michelle Peavy. She's a PhD and licensed clinical psychologist. She got her PhD in the University of Montana, and after that, she became a postdoctoral fellowship at the VA Puget Sound Healthcare System, more specifically at the Center of Excellence in Substance Abuse Treatment and Education, CSAT. She works now as a research and training manager at Evergreen Treatment Services, also known as ETS, a very well-respected opioid treatment program located in Seattle, Washington. We are so very lucky to have Michelle because she's really on the front lines of the opioid epidemic. She provides direct clinical care to opioid users while she supervises other people and develop and implement clinic-wide policies and practices to better serve the growing population of opioid use disorders population. In addition to all these roles, Dr. Peavy also directs research projects that take place at Evergreen or ETS. Michelle has authored several peer-reviewed articles pertaining to substance use disorder, and before joining ETS, she used to be right here with us at Alcohol and Drug Abuse Institute, ADAI, at the University of Washington, where she was a NIDA Clinical Network Scholar. It was a position designed to increase knowledge and skills in implementation of clinical trials in substance use disorder treatment settings. Anyway, we are very excited, and now we are going to transition, and that takes like a few seconds, the slides over to Michelle. Thanks again, Michelle, for joining us.
Thank you, Bia. Can you hear me? Okay, I think you can hear me now. Thank you so much, Bia.
We can hear you.
I appreciate your introduction. And thank you for the opportunity to talk about patient-centered care and opioid treatment programs. And thank you all for those of you out there joining me at presumably your lunch hour. And I'm assuming that my slides are going to come up, but like Bia said, I just wanted to mention I am located at ETS, an opioid treatment program, and we're, of course, an outpatient setting providing treatment for individuals with opioid use disorder. We have a medication-assisted treatment model of treatment, and the medications we use are methadone and buprenorphine. So our setting is really specific and very contextual, but perhaps some of the concepts and ideas I talk about today will be or could be mapped onto other settings of those of you out there. So, again, hoping that the slides will come up in a second.
You have to take control of your screen, see if you can do this.
Okay. Oh, I see. There we go.
Yeah, I always take a little second or two to make this transition.
All right. Well, I'll just keep on talking. I'll let you know that.
It's in your hands now. Let's see if you can.
Okay, good.
Hold on, Michelle. I'm going to try to adjust something real quick.
Sure.
Okay.
Okay, it's on our side, it says it's waiting for you to take control.
All right. And I would just advance the slides as I would advance them.
Mm-hmm.
Yes, you need to click in the slide. Yes, there you go. You got it.
Okay. Huh. So, and I would just use the arrow keys.
Yeah.
Oh, there we go. Yay. Okay. Thank you. Thank you, friends at the Alcohol and Drug Abuse Institute. So just want to give you a lay of the land, what we're talking about today. I'm going to define patient-centered care and talk about sort of our version of patient-centered care at Evergreen Treatment Services, or ETS, specifically talking about our retention policy. I'll present some results from an evaluation of our policy and with some clinical implications. And I look forward to any questions that you might have. So what is patient-centered care? And actually a better title for this slide would be, what is patient-centered care and why should I care about it? And why should you care about it? Well, it's a buzzword. I know I hear the term patient-centered care bandied about all the time, but that's not necessarily a reason why any of us should really care about this term. But we do tend to hear it a lot more and more, perhaps because it may be an expectation of you or your organization, and it could be an expectation by folks that fund you or accredit you. You might need to demonstrate that you provide patient-centered care to get funding or accreditation, and if you don't have that mandate now, you may be looking down the line at anticipating or expecting that expectation to come to you. And if you are an administrator or someone out there looking at your budget, that is certainly one reason to begin to care about this term, patient-centered care. And for example, if you're an OTP like ETS, you operate using SAMHSA's federal guidelines, and these are the guidelines that really govern OTPs. And these guidelines reflect in obligations that OTPs, for example, deliver patient-centered care. So could be an expectation. And okay, so it could be that the reason why all these governing bodies are paying attention to patient-centered care is that it's shown to be evidence-based. That is, evidence from medical research indicates better medical outcomes when patient-centered care principles are in place. So why should we care about patient-centered care? It could be because you're compelled by science, and patient-centered care is evidence-based and might feel like a good thing to do. But maybe you've noticed that I just used one buzzword that is evidence-based to describe another buzzword, and maybe you're not compelled by these buzzwords or science. But I think I have something that should get us all on board with why we should care about patient-centered care. And that is simply, it is the right thing to do. Patient-centered care, or treating patients with compassion and dignity, is simply the right thing to do. So notice I'm using patient-centered care. Patient-centered care literature really comes from the medical world. And if you dive into the literature of patient-centered care, you come up with a lot of different concepts and terms, and it could look a number of different ways depending on the setting wherever you are. And so I want to define for you what sort of our version of patient-centered care at ETS. And we really are consistent. We view patient-centered care as being consistent with our core values at ETS. 3 of those, this is not all of them, but 3 of them are compassion, empowerment, and collaboration. And to kind of operationalize a little bit more what we mean by patient-centered care in terms of these values. So in terms of compassion, we developed a clinic-wide policy to ensure sort of low barrier to get into treatment and high tolerance for remaining in treatment, and really avoiding punishing measures like discharging people at all costs. So I'll talk a lot more about that. In terms of empowerment, this is a little bit operationalized. Maybe we can talk about this more, but really allowing patients to be the agents of change. So really promoting autonomy. And then in terms of collaboration, shared decision-making in treatment planning and in goal setting. And patient satisfaction is a is a cornerstone of patient-centered care. We did conduct a patient satisfaction survey. I'm not talking about those data today, but if you happen to be at the ATOD conference in a couple of weeks, you can come see us present on those data at that time. So an important concept in terms of the collaboration. So again, we'll be talking about a policy and then how this affects individual patients. I just want to say OTPs are complex systems, making it sometimes hard to provide individualized patient-centered care for so many individual patients. But just a reminder that at the center of patient-centered care is, of course, an individual patient. And I want to tell you a story about a particular patient of mine. But before we do that, I just want to say, I'll kind of unfold the details of our policy during our time together. But right here from the start, what I want you to know is that about our policy at ETS is this. The essence of our policy is that ETS patients are not discharged from treatment for continued drug use. And again, we'll talk about the particulars. But before we dive in, let me tell you this story about a patient that I work with who I'm going to call Jack. That's not his real name, and several details about his story have been changed. Jack is a patient, though, that has had multiple treatment episodes at ETS, all of which have ended in discharge for ongoing drug use. And under our new policy, Jack came to us. He came to us with daily heroin and cocaine use, and he was able to reduce his drug use significantly. But he struggled to get those elusive negative UAs, or UAs without any substances in them. So under our new policy, we did not shut the door on Jack's treatment. And I actually, like I said, I have the pleasure of working with Jack in counseling. And to me, Jack is the quintessential example of someone who is in that contemplation stage of change. He is swimming around in those uncomfortable seas of ambivalence. He wants badly to change, and change itself is so incredibly hard. So counseling session after counseling session, I'm using my very best motivational interviewing skills to elicit change talk. And as you might imagine, there are moments of frustration with someone like that has this kind of profile. And if I let myself, there are moments of hopelessness. But I shudder to think what life would be like for Jack if we were to shut the door on his treatment. So if we did that, Jack would not have daily contact with our nursing staff who provide, very important caring, assessment, and encouragement. He would not have access to the medication that has allowed him to substantially decrease his substance use. Jack and I would not have the opportunity to engage in a therapeutic relationship I think we both find valuable. And importantly, Jack would be at much higher risk for overdose death. So despite his ongoing drug use, we march on. And Jack always knew that if and when he was ready to embark on change, ETS would be there for him. So then, not that long ago, actually it's now been a while since I had sort of done this presentation a while ago, but he marched into my office, and before we even sat down, he said, "Michelle, I am ready to change." And this was a real turning point in his treatment. And as a counselor, this is one of the most gratifying, moments in someone's sort of professional life. So Jack was not strong-armed into this decision. Under threat of discharge, we did not give up on Jack. He made this decision by himself. We walked with him, next to him, through those rough and uncomfortable seas of ambivalence with our soft metaphorical hand on his back. And we individualized our treatment because everyone has their own individual clock for change. So I have that clock up there. So we did not always operate like this as an organization. So today I'm going to kind of walk you through how we arrived at this place where patients like Jack, who have failed so many treatment attempts in the past, could pursue a different pathway. All right, so starting to talk a little bit about how we developed our policy and the philosophical underpinnings behind our policy. And first, I want to tell you that we treat opioid use disorder like the medical disorder it is. So in this table, I'm contrasting a more traditional substance use disorder treatment framework for understanding and treating opioid use disorder with that of a medical framework. So you'll notice that top row, both sort of frameworks view addiction as a disease. Under the medical treatment one, it's a little bit more nuanced. But it is very different than when you get to that next row about when a person begins treatment. So under traditional SUD treatment, treatment may begin when a person is ready to change or maybe has already made changes. Whereas under a medical model, treatment would begin when someone starts to exhibit symptoms that are interfering with their life. So that third row, under traditional SUD treatment, an increase in symptoms, and for an opioid use disordered person, that would mean increase in drug use, say. That may be a signal to withhold treatment. In other words, maybe discharge someone. Whereas in a medical framework, an increase in symptoms might be a signal to apply different or more treatment in some way. Both acknowledge that treatment is not always 100% effective, but very different than in kind of who's taking responsibility for that failure. And under traditional SUD treatment, oftentimes a patient is blamed for failing treatment. They're not ready, they're not working hard enough, etc. Whereas with medical treatment, the treatment itself is blamed for failing the patient. Okay, so then we're left with, medication-assisted treatment has shown to be a very efficacious treatment for opioid use disorder, but it, like the previous slide said, it's not always 100% effective. So it is, over the sort of large population, very effective. But of course, we all know people who continue to use and don't get stabilized. So what do we do here? What do we do for those people that are just not responding to the treatment? Well, what I'm saying today is that we should continue treatment despite complications, and we get some direction from SAMHSA, this treatment improvement protocol, or TIP 43 on medication-assisted treatment, advises that policies favoring treatment termination for patients who use substances negate a fundamental principle, that longer retention in treatment is correlated highly with increased treatment success. So in other words, it's really important to continue treatment even when people are using, because the longer we can retain people in treatment, the higher likelihood that treatment will begin to take a foothold. So we had this in mind when crafting our policy. And we also had other policy models in mind. So we looked at this study conducted by our late colleague Don Kelson and others at the VA, and they demonstrated that this sort of minimal services, high tolerance model of treatment for people that were continuing to use demonstrated good results in retaining people in treatment and ultimately moving them towards change. Okay, but those of you out there probably know that there are costs to retaining very unstable patients in a treatment environment. And so it becomes this kind of delicate balancing act. And I want to spell out the dilemma pretty clearly here. So again, lots of people respond to treatment as usual, but many, a proportion do not. So we have this choice. What should we do? Should we discharge them as not ready? Or should we adjust treatment and expectations to meet the patient's need? And what happens when we try to strike this balance? It's a tough one. So on the one hand, discharging a person will increase the risk of death, because we know that treatment like ours helps sort of safeguard people from overdose death when they're not with us. And on the other hand, unstable patients in a treatment environment really pose a risk to other patients and clinic neighbors. So there's this really tough balance that we all have to consider, really, and what to do. So we tried best we could to keep all of those factors in mind, and we came up with our policy, which is right here. And I'm going to walk you through it. It looks complicated because it is, but let me walk you through it. So first, right there at the top, that bubble, it says patient has 9 positive UAs or BAs, breathalyzers. We have this threshold of 9 positive UAs. We kind of count positive UAs and breathalyzers as people go along. And 9 is the threshold. And at 9, this is when our policy gets triggered. And what happens after that is this treatment continuation meeting directly underneath that first bubble. And that is a meeting between the patient, the counselor, a supervisor, perhaps other people. And at that meeting, the patient is presented with their menu of options. And in this case, they have 3 options. They can choose to leave treatment. That's that administrative taper discharge rectangle to the right. People always have this option. Good to point out that people always have options. They could opt to go straight to the contemplation track, which is that bubble at the very bottom. I'm going to talk about that later. But most often people are choosing that option to the left, 6 weeks of monitoring or weekly UAs turning point. This is a stepped up treatment option that people can engage in for 6 weeks, where we increase the frequency of UA monitoring. We offer more support in terms of group programming and any other support the person might need to initiate change. At the end of 6 weeks, we kind of take a look, take stock of how that person did. Did they initiate change according to objective biomarker results, UAs and BAs? And we consider success if at the end of those 6 weeks, the last 2 weeks are negative of all substances, and that's considered successful. We say good job, great work, and they're kind of funneled back into treatment as usual, stable status. If they're not able to initiate change, that unsuccessful box, they again have 2 options. And one of those options is to leave treatment. Again, good to know that people always have options. That's one of them. Or they could opt into this contemplation track. And let me just explain a little bit more about contemplation track. So contemplation track is a specific status and treatment that is designed for patients who are struggling with ongoing drug use. Those of you out there familiar with the trans-theoretical model of change or stages of change might recognize its name. So it really is for this group of people that are truly ambivalent. They're in a contemplation sort of stage of change. And to me, that really fits. And we have restrictions for people on contemplation track. And the use of these restrictions is sort of twofold. One is to promote, as it says, a recovery-oriented environment. In other words, we're trying to, for lack of a better word, segregate those in contemplation track, those least stable of our patients, from other patients who are stable in their recovery. And secondly, some of these restrictions may serve as a motivator for change. So what are these restrictions? Just gonna run through them. They have, folks in contemplation track have restricted dosing hours, or they need to move to a different dosing unit. We're pretty non-tolerant about contemplation track people just hanging around or loitering, so they really need to dose, have their appointments, and leave campus. We have certain restrictions on dosing itself. I can get into the details if needed. And there's limited dose adjustments and other kind of access to clinic services like acupuncture and groups. And this is in part due to that sort of segregation model I was talking about. And also we think that this can serve as a motivator. If people want to re-engage more strongly in their recovery, then they'll follow suit. This is the big one. So we don't have tolerance for our contemplation track engaging in, say, bad behavior, such as impairment, loitering, etc. So there's really no tolerance. If someone has a clinic incident report, then they are tapered and discharged. And then other sort of standards that we have at ETS apply For example, people need to leave UAs, and if they don't leave UAs 3 months in a row, that's an automatic discharge. Of course, monthly counseling is required. So these are the restrictions. And again, it's a little bit of a complicated policy. And I know it's complicated. It's actually one of the biggest complaints among staff and patients, but I stand by the complicated nature of our policy, and here's why. This is not an easy issue. And so again, we tried to be as thoughtful as possible, consider all the details, and the result is a policy that's a little convoluted, but we owe it to the patients not to oversimplify. So we tried to create something that was fair and took all those factors into mind. Okay, so you might be wondering, how's this going? And we were wondering that too. We're data-minded people here at ETS, and we felt like, you know, it's important to make data-driven decisions. So we set out to evaluate how's it going as best we could. Keep in mind, this is not a randomized controlled trial. We did what we could with the data that we have. And we took various variables into mind. We used our electronic medical record, and variables we were really considering included retention, rates of success. We also did a staff survey to understand their understanding, attitudes, perceptions about the policy. And I'll also reiterate, we did do a patient survey to understand their experiences and also feelings about the policy. I'm not going to talk about those today. Okay. So I want to mention this evaluation is now getting a little bit old. We implemented our policy in late 2014, and the evaluation period was really late 2014 to late 2016. Okay, so retention is a biggie, remember, because that if we can retain people, then we have a better chance at reaching them and having them initiate change. And what we found was that before we implemented the policy, there was our census 1060, and then after it increased to 1484. So it's an increase of 40% of the census. And that's pretty dramatic. And I just want to say that this increase was related to a number of efforts across the agency, and there are many people to thank for that kind of increase. And we believe that one of the reasons is our policy change. So, of course, we increased the intake rate also during this period of time. But maybe some of you have this experience that you can increase your intake as much as you want, but if you still have a large bolus of people exiting out the back door, your retention will stay flat. So again, we think that this dramatic increase in census was due to a combination of increasing intakes as well as keeping people in treatment. Okay. So now I want to walk you through a little about how our patients made their way through our policy. So again, this is a 2-year evaluation period, and there at the top, it says, you know, the N of 900 or 526. So that is 526 patients were subject to our policy. That is, they reached that 9 positive UA or breathalyzer threshold. And let me just take a moment to point out that most patients did not engage with this policy at all, because most patients are doing just fine. But we're not talking about those patients today. We're talking about the least stable of our patients. So those are 526. And of those, 248 were successful based on our bar, and 278 did not meet that minimum requirement and went down sort of an alternative pathway. So I want to focus for a second on these 248 people. So the important thing here is that 47% of patients demonstrated change simply with the intervention of more closely UA monitoring and the option for stepped-up treatment. So I just want to say I do plenty of those treatment continuation meetings where I meet with the patient and the counselor, and I just want to tell you a little bit about what that sounds like. So might be meeting with the patient and the other team and say, you know, I see that you've been continuing to use substances, and it seems like you're struggling to meet the treatment goals that you had in mind when you entered treatment. So let's see if we can't do something different here. We're going to give you our 100% effort here at ETS. We are going to offer you more groups, more support, whatever it is you need. We're going to increase UA monitoring to help you feel like you're accountable. Sometimes that helps. We'll give it our all, and you also give it your all. And at the end of 6 weeks, let's see where we stand. And we're here to help you. So that's what it took for 47% of struggling patients. And let me tell you what it did not sound like. It did not sound like, if you don't stop using drugs in the next 6 weeks, then you're out of here. So again, just driving the point home that 47% of patients changed without the threat of discharge, and they knew their treatment was protected, and they were still able to demonstrate this change. Okay, but of course, not everybody was able to be successful with that level of intervention. So let's look at those people who were unsuccessful and did go to this contemplation track status. So this is 278 people. And I just want to point out that under our old policy, these 278 patients would have been discharged right out of treatment. But this time around, we didn't discharge them. We did not spend any time processing their discharge paperwork. We did not spend any time worrying about what they were doing out there, feeling fearful that they might die of an overdose. We didn't spend any time readmitting these patients because we know that these are the patients that would turn right back around and come into treatment. We didn't spend any time with induction or other early treatment appointments. So if there are any administrators or finance people out there, you might see how this is a much more efficient use of everyone's time. So let's break down what happened to them. Okay, so it turns out that 35% actually were discharged. And just keeping in mind that these are the least stable of all patients. So they are exhibiting all sorts of other unstable behavior like impairment, you know, missing doses, behavioral incidents, that sort of thing. So 35% wind up getting discharged. About 40% kind of hang out in contemplation track. So they have not yet demonstrated change, and they continue to be served in a treatment environment that ultimately reduces their risk for overdose death. And then just over 30 do demonstrate change and return to, some of them, you know, return to treatment as usual. Another sort of percentage of them do this thing where they kind of cycle through our policy again and again. We have that kind of going on as well. So again, it's a little idea of how people made their way through the policy. Okay, so another way to get a finger on the pulse of this policy change is to ask our staff. So we engaged in a staff survey. It was an anonymous survey, and 33 staff completed the survey, most of which were treatment staff, counseling, medical, dispensary. And we measured attitude and perceptions of policies. And several of these questions people could write in their comments. So I'll do a little bit of qualitative review as well. So one of the questions that we asked, how much do you agree with the following statement? I support what our positive UABA policy does to give patients the chance to remain in treatment even though they're struggling to meet agency expectations. So as you'll see, most people were staff were at least somewhat, if not strongly supportive of this policy, and got a comment that kind of reflects that. I agree that patients should be given the chance to remain in treatment and be able to stay engaged with services that they may not otherwise be involved in. I would like to see patients encouraged by a time limit they are allowed to stay in contemplation and then have another treatment continuation meeting to determine future treatment. I would encourage ETS training on MI, motivational interviewing, to help those who are helping our patients with their ambivalence. I couldn't agree more with this comment, and also we wound up implementing that strategy at a later time. Okay. All right, so I feel like there's some noise at the Alcohol and Drug Abuse Institute that I was distracted by. Okay, so another survey question, how much do you agree with the following statement? I believe that contemplation track status, patients on contemplation track status have a negative impact on the clinic's milieu, dragging other patients down with them. So there is a proportion of staff who slightly agree, even strongly agree with this statement. And so that's definitely a consideration that we should kind of keep in mind. So, and a couple of staff comments to that end. I do believe that contemplation track status allows for some individual patients to continue behaviors that are not in line with the fundamental values of treatment, and that this can be seen by others as ETS not caring about continued substance use. This can be used as a defense or deflection from patients who are also struggling. And this other person has a slightly different viewpoint. Since contemplation track patients dose later than other patients, contemplation track patients have little contact with other patients. So indicating that our model of kind of segregation may work. Okay, and in general, I just want to put out there that we got a lot of opinion. We have a lot of opinions. We got a lot of opinions on this survey. So here's a smattering of just an open-ended question of like, what do you think? And here are some of them. So this is a person who hates the policy clearly. Judging by the number of patients on contemplation, which keeps growing, it is a failure. Countered by someone who says simply, I like it. Here's this comment. It is a moral quandary for me, one I visit quite frequently. I see the benefits of both sides, and in theory, our policy makes sense. However, in practice, I see increased drug use and an erosion of morale at ETS among patients and staff. So what I love about this comment is that it highlights just how thoughtful our staff are. And here is one of our staff members who clearly cares so deeply for our patients and our organization. And this person is really grappling with these difficult issues. So, and finally, I think the policy is in line with the beliefs and values of our agency. And like most things, it can be improved with knowledge gained with experience. So I liked that comment so much that I used it as a header on my next slide to talk a little bit about how we subsequently have been going about trying to tweak this policy and change it. So we're still, we heard a lot from staff, and we continue to kind of elicit staff opinions about this. And the biggest sort of complaint was that it was thought that contemplation track patients are left to languish in perpetuity and erode the morale of other patients. So we have tried to kind of refocus on this group, offer more changes to meaningfully sort of engage in change. So now we have a reassessment of people in contemplation track every 6 months with the option to return to 6 weeks of action. So, people can continue to stay in treatment, and we also want this ongoing conversation with such patients in a very directed and therapeutic way. And we are also engaging in collaborative discussions with both patients and staff. So this includes some educational efforts and really just how can we best serve this group of people. And I've got to say, I've had a lot of individual conversations with staff, and I've sought out several staff members who really do not like this policy at all. And, at the end of the conversation, where people get to is, I don't want to discharge these patients out of treatment, Michelle. I just worry about all the other pieces that we're all kind of managing. And I can so empathize with that. But really, people don't want these patients to leave. It's just sometimes a really hard population to kind of engage with. I mentioned here we should have an all ETS patients survey, which we've actually done, and results forthcoming. Okay, so here's sort of a conclusion or summary statement about the policy as we've just discussed. So the ETS positive UABI policy is a compassionate approach that improves retention, reduces costs associated with admission and discharge, and protects our population from overdose death by individualizing treatment to fit the patient's stage of change. All right, so I am bringing back this picture because it's a brilliant picture. And it also strikes me that there might be people out there that think that the policy is crazy, or maybe you just wouldn't do that in your own setting, or maybe you have something much better going on in your setting, in which case I really hope that you let me know what that is and we can collaborate. But I guess I just want to let it be known that there are a lot of criticisms about this policy and what we've been doing. And I'm speculating that some people out there might be dubious because, again, I've had a lot of conversations with our own staff who are not really fully on board or have criticisms or speculations. So I want to acknowledge that, and I want to call out that elephant in the room. And I would really like to, best I can, address some of the common criticisms that at least I have been hearing from staff. Okay, so this first question, which, trust me, when it's asked is definitely a criticism: does contemplation track work? And so to that I say yes, the policy helps improve retention, as I've stated. And yes, the policy serves to lower risk for overdose death. So what we know is that people in treatment are simply less likely to overdose than if they were not in treatment, even if they continue to use. And this is borne out in the data. But when people ask this question, I, again, want to be sort of empathic because people are interfacing with a very difficult population. And when people ask this question, I think their eyes are trained on the people that are staying in contemplation track month after month. And people see this as a failure or not working. And I would counter that with, when we see contemplation track as a failure, we miss the opportunity to work with them according to their own change clock. And I feel like it's successful simply to have them in treatment because we know we have a chance to reach them. So if these patients were discharged, we'd have no chance to reach them. Okay, so another criticism: what motivation do people in contemplation track have to change? Won't they just keep using? So I think it's important that we all ask ourselves what motivates any of us to change any of our behaviors. So people with ongoing drug use often have many reasons to change their behavior other than program sanctioned ones. So it's important to remember that addiction can be accompanied with profound pain and misery. And it's our job as clinicians to draw out those reasons and draw those out from the patient sitting in front of us. And doing that will really support that internal motivation. So doing this will allow much more ownership over a person's recovery if their change process is driven by their own reasons to change rather than program sanctioned ones. Okay, and then without the threat of discharge, I don't have any tools to keep my patients accountable. So to that I say, we all need better tools. And maybe the Northwest ATTC will have other trainings that will, that can better flesh out some of these tools for us. But again, I want to be empathic to this kind of comment because I think this is just coming from kind of even a hopelessness or despair about how can I help these patients that are struggling so much. And what I think people are saying here is this: that punishment in the sort of behavioral framework, or kicking people out of treatment, which can be very punishing, that can serve as a motivator. And all of us have probably seen this work. We threaten people with discharging them and they step to it and make change. And people's complaint is that that has been taken away, this ability to provide that level, that consequence. However, what we know from behavioral principles is that punishment itself is not very good at prompting long-standing behavior change. Furthermore, it does not work for everyone. So it might work for some people, but it doesn't work for everyone. And punishment is a very easy lever to push, right? We can say like, well, if you don't do this, then you're kicked out. And that is kind of an easier thing to say. And without that easy lever of punishment, I mean, actually, let me step back, because it's largely not a very easy thing for many of us to say. But what I'm saying is that sometimes it takes more time and energy to engage in patients in kind of a different way. And so when we take away this easy lever of punishment, then we have to engage in this more difficult, more time-consuming, harder work, and work differently with patients. So I'm not denying that it's the harder route to take. It is the harder route to take, but we owe it to the patients to try. Okay. There we go. All right, let's talk a little bit about urine. So when I'm around other people in SUD treatment, in the SUD treatment world, what I love is that I can really connect about the idiosyncrasies of our work. One of the idiosyncrasies of our world and our work is that we talk a lot about urine. So is there enough urine, and how is it collected, and who's collecting it today, and is it collected in a hat, and is there enough, et cetera, et cetera. And maybe you've even been in the situation where you've had a patient sign a contract that said, if my urine contains drugs in it, then I will lose my treatment. And, you know, everybody's rooting for this person, and you're waiting with bated breath, like, what does the urine say? And it's not even like a large amount of urine or anything like that. Or conversely, maybe you've been in a conversation with a patient who wants to contest the results of their urine. And you know that once you start engaging in an argument about urine, that conversation is going nowhere fast. So to me, the best gift of the ETS policy around drug use is that we can take urine off the table. So don't get me wrong, urine analysis are incredibly important assessment tools that we have for ongoing treatment. And I know we're not just talking about urine here, but all that it represents, a whole set of behaviors. But when we can stop focusing on urine, we can start focusing on the important things, like what is it that you really want, and what are your goals? So I like to ask what if questions, because they can be really powerful. So what if we could shift the conversation away from urine? What if we could shift the conversation away from policy? What if we could shift our approach away from punishment? Might we slow down, have the real conversation about recovery goals, individualized treatment, demonstrate compassion? So I am here to tell you that I feel as though our positive UABA policy allows me to do those things. And I know that I felt a huge relief when I could shift away from wagging my finger and threatening people with discharge and starting to talk about the real reasons for change and the real challenges to change. Okay, I made it. It's 12:50. Thank you so much for listening. I saw some questions come through, and thank you to the ATTC and my fine colleagues at ADAI. I want to throw out a thank you to some of my colleagues, patients, and staff. And then I also want to make sure my reference page, which is on the last page, I can't get to it, that people, yeah, there we go, that people are able to see that if they want further information. So I'm turning it back over to Dr. Carlini and those of you at ADAI.
Okay, here we are. Thanks so much, Michelle. That was really, really good and very thought-provoking. Thanks for having that. I think I should be in another slide. Oh yeah, no, I'm the right slide. So before we start questions, we just want to remind you that we will be sending We will be sending 2 surveys, one right now after this the webinar, and one in a month. The one in a month, both are very important for our planning for you guys to answer, but the one in a month comes with a free latte associated to it. So we do send a $5 certificate for people responding the second one after the first one, of course. So that being said, we are gonna go to the questions. I should have, can I change this? Okay, sorry about our
It says that I'm controlling the screen. I don't know. Should I do something? Okay.
Okay, sorry about that. Okay, so we have some questions here. One question I can answer, the slides will be available, the whole webinar will be posted right after this in our Northwest ATTC website. Cheryl Cooper's asked something that 9 total or 9 consecutive UAs. And another question about UA, is a UA defined as just opioid or any substance?
Good, excellent questions. Here we're still talking about urine, by the way. Just got to make the mention of that. We can't get away from it. In any case, it's 9 over the course of a year. So we do monthly random UAs. So it's not necessarily 9 consecutive, but it's 9 in a particular period of time. With regards to the positive UA versus negative UA, we're talking about all drugs that we use in the panel. So it includes opiates and it includes cocaine, methamphetamine, and benzodiazepines. And, you know, for this, we're saying a positive is a positive is a positive is a positive. Okay. Hopefully that clarified it.
Mm-hmm. Another question, do you run into issues with payers if insurance criteria for level of care is not met?
Yeah, that's a really good question. So far, we have not. You know, we presented these data at another conference, and our executive director fielded a very similar question. I wish I could have her pinch hitting for me right now. And we haven't had that yet, and it has not been tested, so to speak. I mean, there's been no like litigation, thank goodness. And the other question I think is related to that is about level of care. And and you know, are we providing the right level of care, et cetera? So a couple of things I just want to mention is that we don't have a whole lot of other options for our patients. So there is that sort of a logistical constraint such that we feel like our level of care is really largely what people need, with some exceptions. And secondly, we think that we feel like we can justify the level of care for the most part in an outpatient setting with medication-assisted treatment because the treatment itself is usually diminishing the opioid use, and we can still continue to work on the other substance use. So that's how it's justified.
Okay, we have many questions here, so I'm going to try to limit it. We won't be able to answer everything, but we'll send to Michelle the questions later, and she might be able to respond to us, and we can post in our website. So for clients that fail to present, how much effort is invested in trying to reach out to them? And not very similar, but just trying to get 2 questions here. In terms of the limited dosing times, what times and what if there is a work conflict on these limited times?
Yeah, good. Gosh, I already forgot that first question, but let me address the dosing times. Roughly 11 to 1. And we do make exceptions for people with documented work stuff. And the 11 to 1 is Seattle specific. We have more than one clinic, and I should have mentioned that the evaluation I did was just our Seattle clinic. and, you know, we just tacked it on to the end of the day because we thought that was the actually least popular dosing time. I hope I answered the question. And my email hopefully is somewhere that others could email and ask stuff.
Mm-hmm. Yeah. So are family members involved in treatment?
No.
Okay. We don't have to elaborate. Let's go here. And do you work with people who are on probation and coordinate the treatment with probation officers?
Other good question. So, you know, at ETS, we don't do any of, or at least at the Seattle site, we don't do the drug court stuff. There are patients that, for whom we need to verify treatment. And I've not heard of any big problems with that, but I don't see as large of a caseload. So far, no big problems with that. I mean, I think really, hopefully, this is my optimistic view, what people are looking at is engagement in treatment. That is the most important variable. I hope, you know, probation officers and law enforcement also recognize that. Maybe I'm just looking at the world through rose-colored glasses. I don't know.
One more question. Having limited resources, how do you respond to concerns about the need to balance waiting lists for treatment with the contemplation track?
Oh, that's such a good question. I left off a whole part of this presentation that our medical director typically does, where he talked about why we changed our policy so drastically. And several years ago with the Affordable Health Care Act and other county was able to lift our census rates, we were able to serve so many more people that we have this opportunity to increase the census such that, you know, we don't really have a waiting list because we're trying best we can to serve the need out there. So we've massively expanded services, and it means that we can have this luxury really of having the low barrier, high tolerance policies in place.
Okay. I think we have time for one more question. So here is one. In your example conversation, you said it seems you are having trouble. It seems like you are having trouble meeting your treatment goals in the case of the client you illustrated with, and that you identify in the beginning of the treatment. So the question is, what if the participant goal is reduce opioid use or abstinence from opioids, but not from other substances? Are those valid goals in ETS, or is ETS expect a goal of abstinence?
Yeah, really good question. So I would say that, you know, we are a substance use disorder treatment facility, so we are geared towards having people move towards reduction and abstinence, and we do have that agenda. That said, there are people that you know, state loudly that they aren't interested in reducing or even, you know, eliminating or reducing certain substances of abuse, and they are actually they can stay in treatment without giving lip service to fake goals. You know, that is a fine thing to do, and we will continue to treat them as long as they're, you know, within the other parameters. It doesn't mean that as treatment providers and counselors and dispensers, we are still working hard to move people in that direction, and we continue to do that at every single encounter using a motivational interviewing framework, which really, while it does kind of take a patient where they're at, also has the agenda of bolstering motivation, creating discrepancy, eliciting change talk. So that's my stance, hopefully.
Okay. So thank you so very much again, Michelle. We are wrapping up today. Again, there are many questions about slides being available. Yes, they will be available in our website. You can also individually, there are questions you can send by email. That might be possible too. There is our email address in the bottom of this last slide. Thank you so much for coming, and stay tuned on our next webinar on March 28th. Thanks so much, everybody.